Assalamu alaikum everyone. I'm Dr. Sidra Shakil, a vitreoretina consultant from Karachi, and I welcome you all to this symposium organized by Roche Pharma today, where we're going to talk about changes in treatment paradigm for diabetic macular edema and neovascular AMD with faricimab. I'll first request our chairperson, Professor Dr. Sanala Jan, to please join us on the stage. He's head of department, Hayatabad Medical Complex, Peshawar. We are still waiting for Professor Moin. He's going to join us shortly. I'd like to introduce our panelist, Professor Dr. Qasim Latif Chaudhry, who's a vitreoretina consultant at Jinnah Hospital, Lahore. Dr. Muhammad Amjad, who is currently vitreoretina consultant at Al Shifa Eye Trust Hospital, Rawalpindi. Dr. Naveed Ahmed Qureshi, he's practicing as a vitreoretina consultant at Al Shifa Eye Trust Hospital, Rawalpindi. And Professor Dr. Khurram Azam Mirza, who is a vitreoretina consultant at Rashid Latif Medical College, Lahore. And Professor Dr. Amir Awan, who is from Islamabad, practicing as a vitreoretina consultant at Shifa International Hospital, Islamabad. So this is a disclaimer. This symposium is organized and sponsored by Roche Pharma. And proceeding with the discussion, my first question is directed to Professor Dr. Qasim Latif Chaudhry. So how do you think does the dual inhibition of angiotensin II and VEGF-A contribute to the retinal vascular disease?
Assalamu alaikum. Thank you very much, Roche, for the invitation. So over the 90s, this molecule, angiotensin II, angiopoietin 2 was discovered, and it was identified, and ever since its role in tumor and its role in homeostasis of the blood vessels was studied. And in 2006 it was discovered that it was vital for the parasite dropout and inflammation happening in diabetes. And since 2016 it has been reported that its levels are a lot elevated in patients having diabetic macular edema and patients having vascular disorders. So it has been noted that its level, they are upgraded in human vitreous as well whenever something like this happens. Can we have the next slide, please? So its level is required for the vascular human tissue stability. So if there's any oxidative stress, and we know whenever there's a vascular blockage, the level of oxygen in the tissues is less, and that is what in such stress, angiopoietin level 2, it raises, and once the level raises, then there's loss of parasites, and that leads to inflammation and capillary dropout, and a lot of edema happens. So this new molecule. The other anti-VEGFs, they are not acting on this angiopoietin 2, and I think faricimab, it is one of the drugs which is actually tackling this factor.
Thank you very much, Dr. Qasim. Thank you very much. Now my next question is directed to Dr. Naveed Ahmed Qureshi. Before that, I request Professor Khurram Azam Mirza to please join us on stage and give company to Dr. Sanala Jan. So my next question is to Dr. Naveed Ahmed Qureshi. Do you think more anti-VEGF is important for improving the anatomic outcomes?
Thank you very much. Actually, it is not the volume or amount of the anti-VEGF. It is the quality and the molecule which matters. So clearly in the READ3 trial, when there is a comparison between the 2 milligram and 0.5 milligram of ranibizumab, so almost equal effect, slight improvement in 0.5 milligram as well as far as thickness is concerned, central subfoveal thickness. But if you see the ranibizumab 2 milligram and 0.5 milligram almost same. In another trial of Photon, in which 2 milligram of aflibercept is compared with the 8 milligram, and both Q12 and Q16 week interval. But all three doses as well as interval almost the same effect at 12 weeks. So it means increasing the dose does not matter at all. So if you see the other studies as well as like TINAIA studies, Josmet trial, in which there is, if you change the molecule, if you compare this faricimab with this aflibercept, so faricimab not only equal but also superior in terms of improving the thickness, central subfoveal thickness. So these all trials suggest that faricimab has something superior than the other counterparts.
Thank you very
Thank
much,
you.
Dr. Naveed. Now I request Dr. Khurram Azam Mirza to please shed some light. Do you see the clinical impact of angiotensin II inhibition based on improvement in the clinical biomarkers with faricimab versus aflibercept?
Thank you very much. So, yeah, before we go on to the biomarkers, so we have to see some properties of this molecule. So, in Yosemite and Rhine studies, we can divide this into three things. You know, the durability test, the quantity test, and the speed test. This is what I've thought about this. And as you can see that comparison between aflibercept, a 2 monthly dose, and faricimab 2 monthly dose, and then faricimab treat and extend, which means going up to even 4 months. So the results are quite comparable, and the improvement in visual acuity is almost the same in all three groups. And similarly, the central subfield thickness, the reduction in that is also the same. And can we go back one slide, please, if you don't mind? The important thing here is in this durability test that what's the point then? If all the results are the same, then we can use any of these. But if you look at the other end, the lower right side, that number of injections used in usual 8 weekly dose are about 15 and 14, but similar comparable results were achieved by 11 injections of treat and extend regime of faricimab. So that is the most important thing, the burden of treatment on a patient, on a system. Next, please. And so that was the durability and quantity. This is what I call a speed test, that how long does it take to improve vision. And so in this slide you can see that in about 48 weeks of treatment, faricimab achieved 50% improvement, and with 7 injections only. And that amount of improvement was seen with aflibercept after about 88 weeks. So 48 weeks and 88 weeks, there is a gap of 9 months between the two, achieving 50% improvement. A reduction of the fluid inside the retina, that's the improvement. And unfortunately with aflibercept, they could not reach until that time the 75% percentile, which means that 75% patients achieved with faricimab in about 88 weeks, and that was not achieved with the other injection. So this was the speed that it did that quickly. Now another criteria, this is the, if you take 1 millimeter cube of the center of the retina and you look at the high reflectivity foci, exudates, hard exudates, something like that. So because that they are part of the diabetic macular edema, and if you just count them and quantify them, the amount of reduction in those was much more at about 48 weeks with faricimab, both treat and extend as well as 8 weekly one, as compared to sorry. So this is what this diagram shows, and similarly over here through 100 weeks means almost 2 years, slightly less than that, 8 weekly regime to which led to 52% reduction in risk of ERM. Now when Dr. Qasim just mentioned about the effect of Ang2 and everything. Ang2 or angiopoietin 2 is what causes ERM formation and scarring and all that. So that element in faricimab is really helpful in reduction of epiretinal membranes. And here you can see, as compared to aflibercept, that the amount was about reduction was only 3.9. Sorry. In with aflibercept as compared to 2.5 and 1.5. And if you go on from 1 year to 2 years, again, the amount of reduction was almost half, or 52%, with faricimab. Next, please. And similarly, in Tenaya and Luzerne, these studies, previous one was all Yosemite and Rhine, and this is Tenaya. And the similar results were shown that aflibercept improvement of vision was comparable to faricimab. Now, in this study, especially the treat and extend part was important. This study went up to, in the later part of the study, the injection gap was 4 months with faricimab, and that maintained the vision as compared to 2 monthly injection of aflibercept. Similarly, the reduction of central thickness and the number of injections, as you can see, as 15 injections of aflibercept were almost equal to faricimab 10 injections. So that is the most important thing in this. Thank you. And they achieved now we have to see, how long they took to make the intraretinal and subretinal fluid disappear. You can see that loading dose in when it's given that's monthly in the beginning, and with aflibercept you required only 2 injections when the fluid was gone, and as compared to 3 injections of aflibercept. So again, the speed is there. Now, so we have been looking at AMDs, neovascular AMDs, DME. Now, part of the AMD which we often encounter is the PED. They have divided PED into different 4 varieties. One is just purely serous, then is predominantly serous, then the other one is predominantly fibrovascular, and the last one is fibrovascular, purely fibrovascular. So on the other side are the diagram of all these. The first one is just predominantly serous, then is a mixture. You can see some serous element as well as some fibrous element, and then when there is only scar tissue, we call it fibrovascular one. So both of these, faricimab and aflibercept, they have effect on both these elements. As you can see, they are comparable. 19% predominantly serous were taken into account, and then both of them, it's just showing the patient pool was almost the same. But the difference is there now, the response of PED at 12 weeks and this head-to-head phase with faricimab and aflibercept, 12.3%, which it's actually faricimab versus aflibercept. So the difference is, that aflibercept reduction was less than reduction with the faricimab group, and you can see that it's about 3 times difference. So over here even faricimab was found to be much more effective. And on the right side, you can see that the gap is there after every 4 weeks, 8 weeks, and then looking at 12 weeks, the gap remained. Always the faricimab group had better results with reduction of fluid in the PED. So this is about the PED. Next, please. And now coming to the biomarkers. Biomarkers are basically something which you can quantify, and in real life you can look at them, and then you can judge by either looking at the picture of the fundus or doing OCT and other things. So there are 4 things: new vascularization, vascular leakage, inflammation, and fibrosis. And we know that the VGF alone will cause neovascularization, and it will cause vascular leakage. So an anti-VGF will control neovascularization and vascular leakage. On the other hand, the Ang2 causes vascular leakage, inflammation, as well as fibrosis. So only with an anti-Ang2 you can control vascular leakage. You can control with both, but inflammation and fibrosis is only controlled by Ang2 receptor, anti-Ang2, and this obviously in turn will reduce the fluid. You will see on the OCT, that's the clinical biomarker. You will see reduction of the high reflectivity foci, exudates and everything. That's another biomarker. And you will see reduction or less production of epiretinal membranes with this. That's another biomarker. This was mostly in DNEs. But if you look at retinal vein occlusion, similar kind of reduction. Over there, neovascularization is not the problem unless you've gone into rubeosis. So the active part is only leakage. So that is controlled by both of these, the Ang2 blocker and the VGF2 blocker. Thank you very much. So these are the real life biomarkers you can look at. Thank you.
Thank you, Dr. Khurram, for a very elaborate and insightful discussion. All right, so my next question is directed to Dr. Amir Zaban. Do you think retinal drying is important for improved visual outcome? In an era where, different agents, anti-VEGF, patients tend to have good visual outcome, they retain good acuity despite having fluid in the macula, how important it is to have a dry retina?
I think it's very important to have your macula dry, and especially you don't want to have the sawtooth pattern, because sometimes if the fluid is coming and going back again, especially that thing can happen in the diabetics or AMD, it is going to affect the vision for a long term. So if you look at the Hawk and Harrier trial post-hoc analysis, and that's about the brolucizumab and compared to aflibercept, we can clearly see here, if we get the early resolution of the fluid, patients will have a better vision and they will maintain a good vision. So here, if you look at the chart here, you can clearly see if it's a fluid free, you are going to get a much better vision, and that keeps on maintained for a longer time. So that's Yosemite and Rhine. That was about diabetic macular edema. I think Dr. Khurram has gone in detail about that. So it's a post-hoc analysis. Above, you are seeing the mean best corrected visual acuity. At the lower side, you are seeing the central retinal thickness, and both are really important. So if you see that central retinal thickness goes down, you're going to get the better improvement in the vision. And that's quite comparable if you compare to the aflibercept. But what's happening here is, here you are getting at 12 and 16 week, you're maintaining that level of the vision, and that the reduction remains low even up till at that time. So which is quite a significant thing. And overall number of the injections is less as well here. So similarly, if you look at the Tenaya and Lucen post-hoc analysis, here above you are seeing the mean best corrected visual acuity, and at the lower side you are seeing the central retinal thickness. And again, it's very important if you compare with aflibercept 8 weekly, here up to 16 weekly, you are getting much better vision in the patients. So their vision level is comparable, but definitely it's a less number of injections you're requiring in this patient. And even your central retinal thickness, although comparable, but it is achieved with a less number of injections, and it is maintaining for a long time.
Thank you very much, Dr. Amir. I think we all want to see our patients' retina dry at the end of treatment. That's the treatment endpoint. Coming back to Dr. Khurram Azam Mirza, how does faricimab improve outcomes in the real world in neovascular AMD and diabetic macular edema patients in your practice? I think it's too early to comment, but still the data coming worldwide. What is your opinion on that?
Yes, obviously, the real experience in this audience would be Dr. Shehzad Shafqat, because he has he's been doing that for 2 years. We have only started a month ago, and I've given like maybe 25 to 30 injections of this, and we actually took out our notes, and patients who were on list for injections, we started looking at them. We started looking at the slightly non-responders, and so those were the ones we selected and obviously talked to them, and the other ones were the new ones, and diabetic ones, again, patients who were totally settling down, and with the other injection we did not change them yet, because we'll have to get more data on that, which we will have in another few weeks when the patients will be coming for follow-up. And but basically the non-responders, PEDs and all those we have shifted. And actually some of them were doctors, and the doctors, we had different kind of discussions with them, and they reverted back to us, and they informed us after 3-4 days. Very strange comments, all of them. When they called, we have had injection, our heartbeat stops, because we are always thinking of infection and other things. But no, they were going to give us a good news that they actually felt different with this one. They had the immediate response within 3-4 days, which they never had with the other injections. So that was very heartening, and so that's basically it for now, and hopefully we'll have more data.
Thank you very much. Now at this point I'd like to direct a question towards Dr. Shehzad Shafqat, who very well presented the far right and far retina studies. What is your experience about the real world data on patients having neovascular AMD and diabetic macular edema?
Our experience is quite positive, and I think all the aspects have been covered in the previous talks. Like the original studies, the pivotal trials, we also saw that treatment-naive patients did much better than the treatment-experienced patients for obvious reasons. I mean, the original trials that Tenayan, Lucerne, and Yosemite and Rhine clearly show that both drugs are equally good
Effective
at improving vision and central foveal thickness. So they were both non-inferiority trials, and they did prove the point that the drugs were equally effective. But the key thing here is durability, and in real practice as well, we are able to extend the treatment. We now got 2-year data, but I only presented the first 8-9 months of data. And I think the second thing is going to be its effect on epiretinal membranes. We know ERM is associated with a longer-term poor visual outcome. Amir touched upon the seesaw, the sawtooth effect, which is yo-yoing of fluid. And most trials show that if you have a more smoother fluid outline, that is in the long term is supporting better visual prognosis than a sawtooth effect of central foveal thickness. So I think we are quite happy with the treatment. We are seeing, and we are able to extend up to 16 weeks, especially in treatment-naive patients. One thing about this has been discussed as well is the effect of faricimab on independent trials. So we only treat patients with the injection who have a predominantly microvascular
PAT.
There's a seamless component which is the dominant, and we avoid
Giving injections.
risk of
Thank you very much for your insightful experience sharing. Now I'm directing my next question to Dr. Amir Rawan. What is the neovascular AMD protocol that you follow at your institute?
Yeah. So if patient comes to me and it's a new patient, so initially what I would do is I would like to have a OCT and OCTA And once doing my diagnosis, I would like to do 3 monthly doses. Once I've done that, so every visit when the patient is coming, so I may not be doing OCT, but I'll check the vision, and that gives me a clue about that how the things are doing. And once the 3 injections are given, then I will do OCT and see how the progress is. That if the fluid is completely resolved, I may, in some patient, depending on the patient, how is the macular new vessel component. If it's more, I may extend 2 more monthly injections and then review again, or I start treat and extend from that time. And depending on that, so 2 weeks usually, I increase the time interval. I'll give injection and see my progress, how the things are doing. So that's in wet AMD. But in the diabetic macular edema, I think that is for Dr. Amjad. Yeah, sorry.
You can
No, not at all. So that wasn't planned.
Thank you, Dr. Amir. Now, the next question is directed to Dr. Mohammed Amjad. What is the diabetic macular edema protocol that you follow at your institute?
Okay, so in DME patients, every patient gets the vision on the first visit, everybody gets the OCT. If it's a center involving, then we proceed with the anti-VEGF, otherwise we opt for the other options. And if it's a center involving, we do not go for the 400 micron in Pakistan, but if any macular edema above 320, we go for the anti-VEGF, 3 injections, and on the 4th visit, they get the OCT done. And then we plan, treat, and extend. If it's not center involving, the vision is still good, we observe and we try to optimize the cardiovascular risk factors. And some patients where there is a lot of exudation, I prefer steroid injections as well in those patients. So this is what we do.
Thank you very much. So again, Dr. Mohammed Amjad, would you like to tell us what is the importance of loading doses in your practice?
Loading doses, I think we need to go to the basics. What is happening in the pathology, retina diseases in terms of the vein occlusions or the AMD or the DME. So the inflammatory markers, the cytokines, VEGF, and the Ang2 levels, they are going to go up. Can we move to the second slide? So what we are looking at is when we give the injections, anti-inflammatory anti-VEGF injections, the levels of the Ang2 and the VEGF goes down, and with all the anti-VEGF they go down. But with the Vabysmo, the best thing is just sir ne aapne kya ki the speed test. The speed test, if you see the graph, there is a dip, and that dip is very sharp dip. Whether you see the red line or the blue line. So once we achieve that dip, what we need to do is to maintain that and not get the seesaw appearance. And up to 6 to 8 weeks, if you see the graph, the levels are pretty good, but then it starts to come back again. So we need to keep on doing the more injections to maintain the sustained effect of the anti-VEGF and avoid the seesaw. Interestingly, in the Lisbon meeting, Varun Chaudhary from Toronto, he presented the case series from his center, where he was trying to start the early treat and extend rather going for the full loading doses, 4 loading doses. And in terms of the diabetic macular edema, he was able to, in the cases where he was able to get the dry macula, he was trying to extend the duration early on rather waiting for the 4 injections. And I think in Pakistan, we are very lucky that majority of our cases are DME rather AMD patients. In Al-Shifa, 85% workload is of the DME and the 15% is the AMD and the RVO. So the answer to your question, yes, we need to do the loading doses, but in some subsets of the patient where there is a early dryness, in a DME cases, there might be opportunity to extend early on, but we need to wait for the data coming from Varun Chaudhary from Toronto, I guess. I think with the previous graph showed the Vabysmo is controlling the levels up to the 16 weeks, and 62% of the cases they were able to extend up to the 16 weeks intervals. And the summary, what we discussed already, I think in AMD, DME, the best way, the basic sciences says that we need to give the loading doses. All the, if we see the DRCR, Eylea injections, we उसमें देखें तो the 4 loading doses उधर भी हम जा रही हैं. So we need to achieve the speed and we need to achieve the durability and not to get the seesaw effect.
Thank you very much. This brings us to the conclusion of discussion from our panelists. Before we move on to open the house for questions to the audience, I would like to take comments from our chairpersons, Professor Dr. Moin and Dr. Sanola. Professor Moin, would you like to make any comments?
I think listening from all the panelists, it's definitely a very good drug to be introduced in the market, that you are extending your treatment, you're available to take it to 4 months. And I think the way forward is to reduce the number of injections the patients are getting, especially in AMD, you can go up to 4 monthly. And in DME patients, the disease as such slides down over time as well. So probably you can extend further on those patients compared to this. But I think this is something which the one thing I've noticed since I've started using, it's a bit slightly viscous than the other medications which we use. So if you are using it for the first time, you don't take it as a surprise. It works well. No problems with the drug as such.
Thank you very much. Professor Sanola, would you like to share?
Okay. If we go back to before the era of anti-VEGF, laser were there, and sometime we would use steroids in some cases. Even for AMD, macular photocoagulation study, and then for DME there was macular laser. For retinal vein occlusion there were lasers, and then VEGF was discovered, and they found that there is a factor which is, and then anti-VEGF role was established in 90s. Later on, they found out there is many other inflammatory mediators, and this Ang2 was again another factor. They inhibits macrophage infiltration and ultimately have sustained effect. Then this anti-VEGF business or market, this is billion of, globally there's billions of dollars behind this business. So in a way, in the start, we were very excited with for AMD, like we all know that verteporfin came in and photodynamic therapy and everybody was saying there was so much good results and everything is okay and there's no harm. But later on they realized that there is some damage also there, and then the anti-VEGF era came, and then we were again excited that now there is improvement in visual acuity in all these. Before there we would just talk about stability, but then there was improvement in visual acuity. If we come to our community or Pakistan, by anti-VEGF practically we mean Avastin, and that is just because of the cost which is there. All the others, and we are thankful to all these pharma people, because if they would not be available like say Petizra, Eylea, or now Vabysmo, we could, even if somebody can afford it, we couldn't do it because they were not available. So first of all, it's good that they are now available. And with this, the problem with the anti-VEGF that you have to repeat them again and again, every month in the start. And then there are integral complications with anti-VEGF injection. And the most feared one was endophthalmitis. So all the scientists and researchers were thinking how to prolong the effects of these anti-VEGF and how to avoid these complications.
And second would be that uh, its effect like fibrosis, epiretinal membrane formation and things like that. And then in some of the cases, the anti-VEGF would not work, like in AMD, and sometime our pigment epithelium detachment you get. And then you see that there is no response to your anti-VEGF injections. Same, probably it's not yet approved for central serous retinopathy related pigment epithelium detachment. But that pigment epithelial detachment is also not responding to anything in my practice. We were doing anti-VEGF, but we stopped actually treating pigment epithelium. And sometimes pigment epithelium detachment would be just under the fovea and would compromise the vision severely. So all such cases, these were our problems. So this new drug, because they are saying it's decreasing inflammation, it's causing less fibrosis, it is expected to have prolonged effect compared to all the anti-VEGF there. So we are excited, and let's see what's coming in the near future. Probably the problems which we were facing, they may stay, but to some extent we will be able to combat all these pathologies.
Thank you, Dr. Professor Sanola. I think Professor Khurram would like to add a comment.
Just a real life experience. Like Dr. Amjad has just mentioned that in some cases he would add steroid, and so I also have a low threshold for adding steroid. In cases with a bit of scarring and AMD bleeding, I used to give a posterior subtenon steroid, especially with vein occlusion ones and diabetic edemas and all that, in addition to anti-VEGF. So we'll see with this Vabysmo, because it has an anti-inflammatory component to it as well. Maybe the requirement for that steroid will become less, or maybe we can still add it. So that's one thing to note. The other thing is, Professor Moin just mentioned, that it's a viscous injection. So the advantage of that I've seen is, when you're giving an intravitreal, then you try and hold the needle site to avoid regurg, and still sometimes you do get regurg. So with this, actually the regurg chances are much less. It doesn't come out. It doesn't mean that you don't hold it, but not for that long. It may be different for vitrectomized eyes, but in actual fact. The other thing is, obviously, we will not go into the detail, the amount of injection in the vial and everything that we can discuss on our own. But just keeping in mind that the neck is slightly broader. Takes a little time for the injection to come down to the neck because it's oily, it sticks to the wall. But so keep it down, and neck is slightly broader, so it'll flatten. It's not very easy. So, but other than that, it's up to you. We can discuss that later on. But I found it to be very useful. Thank you.
Thank you very much. So we also have a very esteemed and experienced retina consultant who's joined us from across border, Professor Lalit Kumar. And you've been using faricimab in India since December. I would like you to share your experience regarding the use of drug in your practice.
Yeah, thank you so much for asking me to. You see, I gave my first faricimab in January of this year only, and have given till date 72 injections of faricimab. You see, whatever data is being presented, I know it's a sponsored kind of meeting. It does work. It does work. My experience is primarily on AMD rather than DME, and but the speed of injection, I haven't found it so well actually. It works definitely at the drying effect, because what was being mentioned by the duration definitely improves. The duration of effect definitely improves to Q12. One of my patients has already received 7 injections. That lady has received, and she did improve from 624 to 6/6. She is maintaining now 6/6, and she is now on Q12. Because initially 4 doses I gave monthly, And because wow effect, somehow I did not find the wow effect which I found with this brolucimab. There are so many biosimilars also now available. So the experience is growing across India. We are also sharing data amongst all our colleagues as we do with any newer anti-VEGF injection. It's okay. Yeah, all the first generation anti-VEGF agents, it's okay, working. Typified by Avastin. Avastin does very well. In fact, 67% of the world still uses Avastin, and ranibizumab works very well. The key focus on this newer generation or the second gen anti-VEGF agents, which start with brolucimab and faricimab and incoming 8 milligram of aflibercept, is the durability, because we don't want patients to come back repeatedly, but that is what reduces the compliance, and if the compliance goes down, then results also go down, and blame comes on the molecule. So faricimab is promising primarily from the duration point of view. The drying effect is, I think, comparable. You see, there were, remember, all these trials are non-inferiority trials, they're not superiority trials. All of them compare with aflibercept still. Aflibercept still is the number one king, ruler amongst all the anti-VEGF. The only superiority trial of ANG2 was Roxy trial and Onyx trial. Those are the two superiority trials with aflibercept, and they were given off primarily because they did not show any superiority over aflibercept. So these trials, whether it is Yosemite, Rhine, or the Tenaya Lucerne, they are all non-inferiority trials, and they aptly show that it is non-inferior to aflibercept. The number of injections definitely come down. The duration definitely is on the positive side.
Thank you very much. Dr. Shazad Shafkat would like to make a comment.
I'll come up.
Professor Tariq Aziz.
Before, I would like to add one thing. First of all, welcome Dr. Lalit Bhai. Welcome to आपको visa मिल गया, माशाल्लाह. We have been talking to each other on the email and all that. Welcome to Pakistan and actively participating in our session as well. You're welcome. The thing is that no doubt, as Amjad and Dr. Khurram has mentioned, that DME is certainly a very challenging task for us, particularly in our setup, rather than ARMD. And Amjad did mention about adding steroids at some point. Would you give steroids suprachoroidal or intravitreal, number one? Because besides me, Shazad Shafkat say that we don't use suprachoroidal at all currently. Do you use that? No, they don't. So what is the parameter? Where will you add the suprachoroidal and which method you are going to use? Let's have a word with Shazad Shafkat first, and then the house is open for the further discussion on this subject.
Oh, so you've added another dimension. I was just going to initially talk about brolucizumab, which Lalit mentioned. I was the first in the Midlands region to use brolucizumab, and I still have about 60 patients on brolucizumab, but we are not recruiting any more new patients for two reasons. One was the intraocular vasculitis, the severe occlusive vasculitis incidents, and secondly, faricimab wasn't available then, which is a more durable agent. The thing with brolucizumab is it's an excellent drying agent because the molecular weight is such that when you give 0.05 ml, it just completely floods the vitreous. Nothing gives more molecules of active anti-VEGF agent in the same amount of 0.05 ml than brolucizumab. It's a very, very tiny, with 26 kilodalton size. So it's an extremely small molecule. And so it was very effective at neutralizing VEGF-A. But of course, it had issues, and we stopped using it. The second point about the steroids is that we don't use suprachoroidal, not because it's an inferior technique, but we just don't have popularized basically suprachoroidal injections. But I've been using intravitreal intrasenol, which is the only triamcinolone which is licensed for use in the eye in the UK. In US there is Triessence, but we use intrasenol, and it's very effective. The problem is it lasts, the amount that I use, which is 2 milligrams only, lasts for 6 to 8 weeks only. it does the job, but obviously it needs repeated injections. And of course, every time you go into the eye, there's a potential risk of endophthalmitis. So that's why, of course, we've been using Ozurdex and Iluvien, which are much more durable injections, but they're not licensed for AMD. Intracenol works very well, and I'm sure Amjad will share his experience of using steroid, but we use intravitreal injections.
Ozurdex is not registered in Pakistan. It's not available. It costs a hell of a lot of money. Few of the patients, they usually bring from Dubai and all that. So Amjad, please carry on with the experience with the
Sir, जो Ozurdex था last time मैंने जो लगाया 2-3 महीने पहले, the patient had to get it from Dubai. For 7 लाख का पड़ा था उसे.
What?
लेकिन he was affording, he got it himself, और मुझे उसने 7 लाख का बताया. I don't know कि क्या किस तरह कहाँ से उसने लिया, क्योंकि मैं उसमें involved नहीं था.
Yeah, I'm a big fan of Ozurdex actually.
Yes.
You see, it's easily available in our country.
Yes.
And the cost is dirt cheap, 25,000 rupees only.
Wow.
And it's 25,000 rupees.
साथ लेते हैं कुछ.
So my threshold of in DME, we are talking of DME, not
Yes.
NAMD. DME, my threshold is very low. If patient does not respond adequately to 2 or 3 injections of aflibercept, then immediately in DME we shift. Especially if the patient has more of hard exudate, especially if it is SRF predominant fluid or HRF is there, or there is some other contraindication of use, then immediately shift to Ozurdex, and response is phenomenal. And the average duration which I found is 3.5 months.
Yeah.
3.5 months is last. And one eye I have already given 21 injections of Ozurdex. That is the largest number I have.
Sir, unfortunately, price की वजह से we don't have the access to.
And I don't care whether the patient is fake cake or not.
Yes.
It does not matter at all.
Yes. I
Dr.
think,
Amir Rahman would like to make a
sir,
comment.
इसमें
Sorry, can I have a comment, please? Ismail Dochi, there are 2 things that I think this was, first of all, I welcome Dr. Lalit and all the guests here. And it was a wonderful discussion on this new drug, but just one question to the people who are giving this drug, new one, that is there any case of inflammation found out of all this real world experience? One. And the number 2 is that this is very important to know that it's the stage of the disease which also matters at the results, Standing of the effects of the disease, where we have to take into that parameter also in consideration.
The comment.
Sir, steroid का in terms of Dr. Shahzad, intracenol is not it's not licensed for as a treatment. It's for a vitreous staining. Lekin have I used it? The answer is yes. Only in the patient who are affording 60 pound का पड़ता मुझे. जो the patient who are non-responders or non-affording है, उसके लिए I use the Canacort. It only cost me less than £1. उसके अंदर से ऊपर से I remove all the alcohol liquid and then I only use the powder and I use intravitreal. Yes, ठीक है. अब अगर मेरे पास नहीं है, patient is completely non-affording है सर, और वो £1 की भी नहीं चीज़ ले रहा, 50 की भी नहीं ले रहा, then I go with the local manufacturer जो है, और then I go suprachoroidal or orbital floor. Yes.
Yes, so
You're right.
end up giving more than 2 milligrams.
Yes.
But people have been using 4 milligrams for years,
Yes.
and it does. And you're absolutely right. I mean, intracenol only became available about 3 years ago.
Yes.
Prior to that, for about 10, 12 years, I've been using Canalog, the same as
Yes.
the orthopedic surgeons use for.
But intracenol
you're
works very
absolutely
well,
right.
sir.
We used to keep it for about 5 minutes without. So normally, previous to when we came to find out that the alcohol bit was causing inflammation,
Yes.
we used to shake it vigorously and
Yes.
then inject.
Yes.
But then we stopped doing that and let it settle. All
Yes.
the alcohol would come at the top and then go from the depths of the ampule. But I was still using 0.05 ml, which is 2 milligrams. But
Same here, sir.
probably ending up with 3 to 4 milligrams because of the crystal.
Yes, intracenol is a preservative free, so it's
Yeah.
good and the results are good. Sir, coming to one of the points you mentioned about the inflammation, is there inflammation after the Vabysmo? The answer is yes. There have been few cases reported. इंग्लैंड में भी मैं अपने पीयर्स या कोलीग से जो बात करता हूँ, हर सेंटर में 1-2 केसेस हैं, लेकिन दैट इज नॉट ए साइट थ्रेटनिंग, ठीक है. अनलाइकली ब्रोडिसिज्म के जिस तरह के वेस्कुलाइटिस आए थे, दे मेजॉरिटी ऑफ द केसेस दे आर एंटीरियर यूवीआइटिस. व्हाट हैपेंस इज के इन ब्रेडफोर्ड या यॉर्क में जो मेरे कोलीग काम कर रहे हैं, दे स्टॉप यूजिंग द वाइबेस्मो एंड इन्फ्लेमेशन इज गॉन विद अ टॉपिकल. साइट थ्रेटनिंग नहीं है. आई थिंक येस्टरडे भी इस तरह की टॉक में somebody was mentioning about the end of thermitis. I think we need to जो 7 केसेस जापान के कोई मेंशन कर रहा था, आई सर्च्ड ऑन द गूगल, आई कुडंट फाइंड एनी. आई थिंक प्रॉब्ली ही वाज मेंशनिंग अबाउट द इंट्राओकुलर इन्फ्लेमेशन. इस ड्रग के साथ है, यस है, हर सेंटर में 1-2 केसेस हैं, एंड द you don't challenge those patients again with the Vibesmo, you just shift to the other one and the inflammation is gone.
So, sorry.
The safety profile of Vibesmo definitely is higher, but in 2023-24,
Yes.
Insignificant number of patients have been reported. You see, all these are proteins which we are injecting monoclonal antibodies, and there is bound to have some inflammation. But like you rightly said, they are not site-threatening.
Yes.
So the fear factor, both from the surgeon point of view and patient point of view, is not alarming compared to the patient or the
Brolucizumab. तो सर कल भी मेरा ख्याल है थोड़ा सा ज्यादा था. आई थिंक देयर इज नो एंडोथेल्माइटिस एज सच. 7 केसेस मुझे नहीं मिले. सर आपका व्हाट डू यू थिंक सर?
So I've been using it for more
Yes.
than 2 years now, and I haven't seen any occlusive
Yeah.
vasculitis. That's what we worry about. But anterior segment reaction, vitritis is there, but
Yes.
it's there with Eylea as well as you know the other
safety profile
drugs.
seems
So-
pretty good.
Depending on, I mean, if it's just iridocyclitis or iritis, then topical. But if there's vitritis, then we give a touch
Oral.
of oral steroids as well. No. But you know, as Amjad said, once you do get a reaction, the second time reaction would be even worse. So we then go back to Eylea.
What do you think would be the ratio? 2 years, what would be the ratio of those inflammations?
So, I mean, the total numbers are small, but if we go to the pivotal trials, there was slightly more inflammation in Vabysmo group than the Eylea group, in Tenaya and Lucerne, and even in...
Sir, 1% से less, 1.1% शायद document हुआ है. I don't remember on the top
so
of my
it's-
head.
it was around 2%, but then all of them were able to respond to steroids, topical and oral. But the thing is, I mean, you don't go back to injecting the same agent again.
You don't challenge them again.
And I think as far as I recall, in the studies, the proven endophthalmitis was out of 25,000 patients, it was about 3 or 4.
Any trick for actual injection? You said it's very viscous. So any trick for, I mean, for the needle point of view?
There are many tricks.
Sir,
what we do is that
Sir,
meeting
I think those can't be discussed on the forum here.
You can know what we do
Yes,
is keep
there
it
are
out,
many tricks.
keep it out at room temperature for half an hour before, so that that oily nature or stickiness goes away. Whereas if you take it directly from the refrigerator and inject, it is actually difficult. It is actually difficult to inject. Yeah, 20. Yeah, same.
We usually use with non-detachable needles. If you insulin syringes, because if you use the detachable needle, there is a chance when you push it, then it is possible to, because it's a viscous. No? We usually use a non-detachable needle, 30 gauge needle. You can push hard, but yes, if you compare it with the ranibizumab or with the Eylea or with the Western, you need more force to inject. Definitely, this is there.
As far as the inflammatory response is concerned, which Amjad was talking about earlier,
जी sir.
I think amongst us at this moment in time, Dr. Shehzad Shafkat has more experience using for 2 years,
Yes.
and he is a pioneer person in England who started the trial.
Yeah.
Nobody can challenge that point, and he also mentioned the rate is very, very low as far as his study is concerned. He briefed for whole 2 days. He was explaining to us it's not much. So we
Yeah.
will take the words of Shehzad Shafkat,
Exactly,
number one. And number two, he just mentioned a very good technique yesterday. Just tap the syringe. Don't bang. Just tap it gently. It will work. Am I right?
Yeah, so it's a bit more frothy when you're withdrawing it in the syringe. One point about what your colleague said. So we use detachable syringes, but they're Luer lock syringes, so they don't come off when we inject. And besides, the force is not much. There is a little bit more resistance, but it's negligible. But when you draw it up, it's a bit more foamy, it's a bit more frothy. So what I tell my trainees is just to tap rather than flick, because by flicking, you're releasing the silicon lining from inside.
Nice.
So it releases the silicon, and it's the silicon that gives rise to inflammation and arthritis and stuff. So just tap it gently. But now, when I go back, I've been assured that we'll be getting
Silicone-free syringes.
the pre-filled syringes, so
Pre-filled.
there won't be any more need for.
Well, we are not in favor of pre-filled syringes. हमें तो vial चाहिए भाई, vial. सीधी सी बात है. We look on the more on the economic side
Exactly,
rather than
sir.
having a pre-filled
सर हम
syringe.
तो वो टैप करने से भी डरेंगे कोई एक आधा कतरा ना लूज हो जाए सर.
Exactly.
So that brings me to a question that while you're using it from the vial, do you like to take out all the doses at the same time, or would you just use one dose and maybe keep the vial for next time use?
आउट ऑफ मीटिंग हम डिस्कस कर लेंगे.
Off label question.
Off label.
आपने कहा रूम टेम्परेचर पे जब लेके जाते हैं वो कहते हैं व्हेन यू टेक इट टू हायर टेम्परेचर उसके अंदर कोई बैक्टीरिया वायरस हो तो वो एक्टिवेट हो सकते हैं.
लेकिन उनकी भी आप इंफॉर्मेशन देखें ना, दे आल्सो से कीप इट आउट फॉर सम टाइम. एफ्लिबर्सेप्ट का भी आइडिया का भी आप देखें ना, दे यूजुअली से इट के कुछ टाइम के लिए.
Thank you very much. So I'd like to extend my thanks to all the chairpersons, panelists, and audience for having a very healthy discussion. Can you please come forward for a group photograph, and then we wind up this session. Thank you very much.